Today's topic that I chose is prolapsed intervertebral disc. Special tests are routinely and frequently asked in the auscultation, and also it is important in the long and short cases, and of course it will be asked somewhere in the MEQ and MCQ as well. A male of 42 years presents with low back pain for 2 weeks following fall from a height of 10 foot. He also complains of radiation to buttock and the back of the legs. On examination, there is sensory loss on outer side of the foot with power in plantar flexion of the ankle, grade 3 of 5. Ankle reflex is also diminished. He was diagnosed as a case of prolapsed intervertebral disc. And what would be the level of the prolapse? It is L1, 2, 2, 3, 3, 4, 4, 5. It is L5S1. So here is, it is L5S1 disc prolapse. So that there is a huge problem for the low back pain as such. The prolapsed intervertebral disc is a small part of it. And most of the population, many say it is almost 80% of the population, they get the back pain somewhere in their lifetime. And the peak incidence is somewhere during the 4th and 5th decade. Very rarely, very young age or very old age. And 95% of the disc prolapse, if it is present, it involves L4-5 or L5S1. And out of these two, L5S1 is the most common one. Most common cause of the low back pain is not prolapsed intervertebral disc, it is muscle strain. Now the question is, can it be resolved? And the answer is 90% of the low back pain resolves within 1 year. And the risk factors are, one is the obesity, smoking is one of them, gender, prolonged sitting and working on the computer, if you can see my cursor, this is a problem. And of course, lifting of heavy weights is one of the problems. The structures that can cause the back pain, almost all these structures, the muscles, ligaments, disc, fascial joints, nerve compression, and many of the times it could be an intra-abdominal structures as well. So when we examine, never forget to examine the intra-abdominal structures when there is nothing wrong with the spine. Common causes, it is herniated or slip disc, degenerative disc disease or spondylosis, fascial joint degeneration, and this fascial joint is a synovial joint, and that's why it is called osteoarthritis here. Can be a spinal canal stenosis, can be spondylolisthesis, can be a fracture, sprains and strains outnumber all the causes. Sometimes can be inflammatory, especially the infection to the bone, tumors, osteoporosis in the old days, and many times could be autoimmune disease, say for example, ankylosing spondylitis. There can be causes which is not related to spine at all, and most commonly we'll find the kidney stone and the infection of the kidney. Sometimes in the female, endometriosis can be a cause from the sacroiliac joint due to infection, strain, or there is too much or too little movement at SI joint. What happens when cause of the back pain cannot be found? Should be worried. It is not always possible to identify the cause of the back pain. And if you don't find, don't be disappointed. It is rarely anything serious to your patient. The classification of acute and chronic is probably arbitrary many times. How to determine whether it is acute or chronic? The duration of the pain determines whether it is acute or chronic. Acute, when we say, we mean it is within 7 days, and most of the back pain, they fall in this category. The subacute is somewhere between 7 days to 7 weeks. The chronic back pain, if it is more than 3 months. There is some diagnostic dilemma. There is a problem in diagnosis. The problem is that exact localization of the source of the origin of the pain is very difficult. There is significant overlap of the nerve supply to many of the discs, muscles, ligaments, and other spinal structures. Many times it is difficult for the brain to accurately sense which structure is the cause of the pain because there is overlap of the nerve supply. There is one example that you can see. A degenerated or torn lumbar disc can feel the same as a pulled muscle, both creating inflammation and painful muscle spasm in the same area, and that's why there is a problem. What is the meaning of the prolapsed intervertebral disc herniation? Literally, it means protrusion of any organ or the tissue through an opening in its surrounding wall. So it goes out of its confines, penetrating through its surrounding walls. We know a little of anatomy, the disc composition. It is composed of annulus fibrosus and nucleus pulposus. What is the function of the disc? It separates the vertebral bodies, a strong and flexible structure for the movement between the vertebrae that it provides, and it adds to the height of this spinal column. It acts like a shock absorber as well. When does the disc fail? When the intradiscal pressure is higher, then it fails. It can withstand certain forces and pressure. When we are sitting, the pressure is more than when we are standing. Forces on the disc more hitting and leaning forward than sitting upright. Sitting, it has got more forces on the disc than standing. Standing has more forces on the disc than lying on the side, and the least force or the least load is on the disc when a person lies supine. Rotation combined with the flexion are the worst position for disc injury. There is some nerve root mismatch between cervical and lumbar spine. Lumbar spine L5 nerve roots, this travels under L5, whereas the C6 nerve root travels under C5. So there is a mismatch between the two. And this mismatch is corrected by C8 nerve root. There is no C8 pedicle. Cervical one, it is the horizontal, and whereas in the lumbar, the vertical anatomy of the nerve root. Because of the horizontal anatomy of the cervical nerve root, a central and foraminal disc will affect the same nerve root. Whereas in the lumbar region, because of the vertical anatomy of the lumbar nerve root, a paracentral and foraminal disc will affect the different nerve root. It is not the same. 95% of the prolapsed intervertebral discs that we have seen already, it affects L4, L5 and L5S1, and L5S1 is far, far more common. The incidence is 4th and 5th decades, and only 5% become symptomatic. Male are predominantly affected in the ratio of 3:1. Before going for any operative procedure, remember 90% of the patients will have improvement of symptoms within 3 months with non-operative treatments. Now let us understand what happens to the protruded disc. Is it relocated to its original place? No. The size of the herniated disc, it decreases over the time and reabsorbed. Whereas the sequestrated type of the disc has the greatest degree of spontaneous reabsorption because there is no nutrition it can get when it is sequestrated. The microphase phagocytosis is the mechanism of reabsorption. What causes excessive forces on the disc? It could be falling from a significant height and landing on the buttocks, This can transmit the force across the spine. Bending forward, this is substantial stress on the intervertebral disc. If patient bends and attempt to lift an object which is heavy, it produces more forces on the disc and then annulus can be ruptured. Intervertebral disc can also herniate as a result of weakening of the outer fibers of the disc due to repetitive minor injuries or due to degeneration with the age. There are some special features of the disc that we will see before going for the clinical session. Cervical spine, the discs are thicker anteriorly than posteriorly, and this contributes the cervical curvature, which is lordotic. Transverse diameter is less than that of the associated vertebral bodies, and consequently, lower edge of one vertebra almost overlaps upper edge of the next, especially posterolaterally. This is seen radiologically. In the thoracic region, each disc is almost uniform in height, and thoracic curvature is primarily due to the shape of the vertebral bodies, not due to the disc. Again, in the lumbar spine, discs are thicker anteriorly than posteriorly, and it adds to the lumbar lordosis. The L4, L5 disc is the largest and therefore most avascular. Predisposing factors for the disc herniation: a job involving lots of lifting, a job involving lots of seating, especially the sedentary job, a job where weight bearing is needed, or in the sports, smoking and obesity adds to the problem. Age is also a predisposing factor because of the degeneration of the annulus fibrosus. Classification, when we talk of, it is based on the location most of the time, and all the doctors follow it. It could be the central prolapse. So the central prolapse often associated with the back pain only, and it in rare circumstances may present with the cauda equina syndrome. Posterolateral or the paracentral is the most common disc herniation because the posterior longitudinal ligament is weakest in the posterolateral part, and the protruded disc usually compresses the next lower nerve as that nerve crosses the level of the disc in its path to its foramina. L4, L5 disc herniation, for example, will affect L5 nerve root. Note that each nerve emerges through upper part of the foramen and lies against the body of the vertebrae above. The third variety could be the lateral. It is also called extraforaminal or far lateral. It can affect the seating upper nerve root as well. And there can be a fourth type, which is called axillary type. Classification can be based on the relation to the nerve. And there are two types, shoulder type or axillary type. Shoulder type means nerve roots are compressed from the lateral side, and axillary type means nerve roots are compressed from the medial side. This is the way the patient will bend. So in case of, say for example, the shoulder type, patient will bend to the opposite side to relieve the neural compression, whereas in axillary type, the patient will bend to the same side, and there can be anatomic classification. It is called protrusion. It means the bulging is there, but annulus is still intact. Extrusion, now the disc material has herniated through the annulus, but it remains continuous with the nucleus pulposus. Sequestrated disc has become free now. It has herniated through the annulus and is no longer continuous with the nucleus pulposus. And we have seen it will degenerate very fast. This is the protrusion and this is extrusion that you have to identify. What are the clinical features of acute disc prolapse? Acute disc prolapse may occur at any age, but is uncommon in very young or the very old one. Patient is usually fit and most commonly they are adult, aged 20 to 45 years. It occurs typically while lifting or stooping, and the patient gets severe pain immediately and unable to straighten up. And in a day or two time, the pain is felt in the buttock and lower limb. This phenomenon many a time is called sciatica. Both backache and the sciatica are made worse by cuffing or straining. Later, there may be paresthesia or numbness in the leg or the foot, and there may be muscle weakness as well. Cauda equina compression is rare. When it occurs, it can affect the urinary retention. So presenting complaint will be, it can range from the little or no pain, can range from severe and unrelenting low back pain that will radiate into the regions served by the affected nerve roots. Patients sometimes may present with the neurological problems only without back pain sometimes. It will be numbness, tingling, muscle weakness, and paralysis paresthesia as well. Pain in the buttock and posterior thigh and the calf can be a presenting symptom without backache also. And sometimes local inflammatory response with edema, it can aggravate the symptoms. The symptoms can be the discogenic. It is when the innervated ligamentous layer of the outer annulus fibrosis is stretched. So pain is acute and it represents partial tearing of the annular tissue. Pain from the ligament stretch is midline and worse with lordotic postures. The radicular pain means the nerve root have been compressed or being irritated. Then the symptom predominant will be leg pain than the back pain, and it will be worse with sitting and improves with standing, worsened by coughing, Valsalva maneuver, and the sneezing, and it is associated with the motor or sensory loss in one or both lower limbs, and worse with sitting, improves with standing. The symptoms could be claudication pain as well. Walking for long distances will evoke pain and radiation. This sort of the phenomenon is called neurogenic claudication. You have to differentiate it from the vascular claudication. Here the pain will be worse with extension, walking, standing upright, and pain is relieved with the flexion. And there can be a cauda equina syndrome, which is an orthopedic emergency. We will be seeing it, bilateral leg pain, lower limb weakness, saddle anesthesia, and there will be bladder and bowel symptoms. How to differentiate from pain of muscle spasm? Pain of the muscle spasm usually like a pulsating pain or pain that comes and goes, whereas herniated disc pain is usually continuous, or at least is continuous in a specific position of the body. So there is chemical radiculitis which is playing a part in generation of the back pain. The primary focus of surgery that we are doing is to remove pressure or reduce mechanical compression on the neural elements. Can be spinal cord or the nerve root. But now people are increasingly recognizing that the back pain, rather than being solely due to compression, may also be due to the chemical inflammation, and that has to be taken into account. And there is a proof of it. The inflammatory molecule called tumor necrosis factor alpha TNF is released not only by the herniated disc, but also in cases of disc tear, annular tear, also by the facet joints, and can be released in the spinal stenosis as well. In addition to causing pain and inflammation, TNF may also contribute to the disc degeneration. The leg pain symptoms, how it will be presenting. It could be burning pain, electric or shooting pain. And what does it indicate? It indicates typical of a nerve root irritation or compression. Aching type of the pain, when the patient complains to, probably it is associated with a spondylosis or arthritis or muscle spasm. And when there is a leg numbness or tingling, it indicates nerve root compression again and weakness of the dorsiflexion of the ankle. Patient will have the foot drop and the gait will be the high stepping gait. What could be the exacerbating and relieving positions in prolapsed intervertebral disc? And spinal stenosis pain, there is a difference between the two. Prolapsed intervertebral disc pain, forward flexion increases the pain and extension relieves the pain. Whereas in a spinal canal stenosis, extension will exacerbate the pain and forward flexion relieves the pain. It is just the opposite. And there is a test for the spinal stenosis, which is called Phelan test. If pain increases on twisting, as in the golf swing, what could be the structure possibly involved? It is the facet joint pathology. So they are the differences between the vascular claudication and the neurogenic claudication. The differential diagnosis can be infective, tuberculosis is most common, ankylosing spondylitis, degenerative disc disease, neoplastic facet-related joint problems, mechanical back pain, and rheumatoid arthritis. Not related to spine can be piriformis syndrome, diabetic neuropathy, pelvic fracture in emergency medicine, and renal causes. And everybody must understand what is the red flag diagnosis or red flag signs. They are the signs and symptoms that indicate the possible or the probable presence of serious medical or surgical condition that can cause irreversible disability or may cause untimely death unless it is managed properly and urgently. And red flag signs are fracture, cauda syndrome, spinal infections, and vertebral malignancy. Thank you very much. Thank you. Finished part 1 of Pivd.